first presenter here is going to be Anthony Love, Mr. Anthony Love, who serves as the Senior Advisor and Director of Community Engagement for the VHA Homelessness Program. So, Mr. Love.
All right. Thank you. Let me walk around here. Well, good afternoon. I know that it's after lunch and eyes are getting a little heavy, so we're going to try to at least make it somewhat engaging and somewhat interesting. Again, I'm Anthony Love with the VHA Homeless Program Office, and the Homeless Program Office. There you go. Oh, too far. There we go. Oh, good Lord. Yeah, at least I'm keeping myself awake here. All right, so the Homeless Program Office, it's not a new office. Actually, VA has been working on the issue of veteran homelessness since 1986. And from 86 roughly up until about 2009, the strategy the VA employed was to ensure that veterans got treatment, made sure that their clinical needs were met. And for the most part, we're pretty much what I would call managing the issue of homelessness in terms of as veterans go through the treatment modality, after they complete that, then help them to find housing. Well, late in 2009, the VA made a dramatic shift where the VA decided that we were no longer going to manage the issue of homelessness, but we were going to end it. That everything that we do with homeless veterans would be towards ending that veteran's homelessness. And so in order to do that, VA had to make a major paradigm shift. It had to shift from a bed-based strategy, meaning that we were bringing veterans in for clinical treatment and so forth and so on, to a housing-based strategy, meaning that helping them to find the permanent housing that they need and wrap those clinical services around them so that they can maintain that housing. And also had to look at the programs that we were offering at the VA to ensure that it followed suit in terms of ending homelessness amongst veterans. There we go. Take my time there. So in terms of making that shift, we had to also shift our beliefs. We had to believe that, one, this is a solvable issue. And the reason that we could make that belief because we were looking at communities across the country and they were making dramatic progress towards not necessarily ending, but their numbers of homeless veterans were going down. And they were going down because they were using promising and best practices that they were implementing. But we believe that it's a solvable problem. We also believe that we must be committed to this issue until every veteran has a safe, stable, and permanent place to live. When we first introduced the initiative to end veteran homelessness, we had the date that we would end it by the end of 2015. This was in alignment with the previous administration's goal of ending homelessness and having ending veteran homelessness by 2015. We made staggering progress by that date, but of course, we still have a little under 40,000 veterans who are homeless. That doesn't mean that we didn't meet the goal. That just means that we have more work to do. And we are not going to be what I would call stymied by a date, but we're going to continue to push forward until every single veteran has a place to stay. And I would say that, and you'll see later in the presentation, the progress that we've made. And also, we believe that homelessness, if we're going to end it all over the country, that it is a community by community effort. VA cannot, 2 secretaries ago, Secretary Schaefer say you can't fix a problem with a 3,000-mile screwdriver. Mm-hmm. So, we can't end homelessness from Washington, D.C. So it has to be a community by community effort. And our role is to make sure that we support those communities, ensure that they have what they need, and then get out of their way. Okay, good. So, how did VA, working with its other federal partners, respond to this call? Again, I think I mentioned earlier we talked about best practices. And those best practices include going to Housing First. Housing First is a best practice, a proven practice, an evidence-based practice, in which the idea is to have the individual go into housing first and foremost, and then wrap the services that he or she needs in order to sustain that housing. The idea is to eliminate the chaos that homelessness causes in an individual's life, provide that stability, and what you see overwhelmingly is they start making decisions in terms of meeting those other needs that they may have in order to sustain their housing. We also looked at practices that are happening in other cities. We pushed forth an initiative called 25 Cities, where we looked at the 25 cities that had pretty much the highest concentration of homeless veterans, and also would have the biggest impact if we were to reduce those numbers, and provided technical assistance in those communities. And as a result of that technical assistance, what we began to see is they developed what we call a coordinated system, where communities started making the issue not a program-based solution, but a systems-based solution. Because the way that we were going to end veteran homelessness is that communities had these systems in place where individuals would be assessed with a common assessment tool, and you're able to match the veteran with the resource that best fit his or her needs. You also have to use data. It seems like one point in time that data was a dirty word, and I remember working in the community. I'm a former community provider and going to the VA talking about let's share data, and I think that it was like an allergic reaction that the medical center had. Like, we're not sharing our data with you. Fast forward, we're still not all the way there, but you are now beginning to see VAs working with the community, sharing that data, working with the community also to make sure that we're not duplicating effort, that we're actually working in partnership with the community, and also measuring the results in terms of knowing precisely how many veterans are getting housed, looking at how many veterans are flowing into the system, how many veterans are exiting the system, how many veterans are getting employed, and just kind of keeping track of that information. That also goes to keeping a by name list, where communities are doing their best effort to know the names and locations of every single veteran within their community that's experiencing homelessness, and using that list as a means to determine what kind of progress that they're making. We also looked at partnerships, and the partnerships were just remarkable. One partnership that we looked at that we were able to spread and really kind of move the needle were partnering with mayors across the country. Working with HUD, USICH, and the White House, we had over 800 or so mayors, governors, and leaders from across the country sign up, make the pledge, we're going to end veteran homelessness. And once those mayors and those other leaders got on board, we saw communities' efforts accelerate. It's nothing like a mayor, making the call saying, "Look, I put, my name on the line, and I want to be reelected, and so I need you to make this effort." One example of that was in New Orleans, where Mayor Landrieu took it a step further. We said we wanted to end veteran homelessness by the end of 2015. He said he wanted to be the first city in the country, and actually did it in December 2014. And he did some pretty creative stuff. He even got the National Guard to come and help do outreach within New Orleans, and got the state to bring in funds, and they also leveraged their local resources with federal resources, and did a phenomenal job. I've already talked about Housing First. I don't think I have to go back through that again. So some of the programs that we revamped in VA is the HUD-VASH program. The HUD-VASH program actually is not a new program. A lot of people are just hearing about it. HUD-VASH actually came about in the early 90s. About the early 90s. And it's pretty much any homeless veteran that needed a voucher, they gave out the voucher. The challenge was with that, not only was the voucher not getting to the neediest veterans, but also what was happening is that public housing authorities, as veterans were graduating out of public housing, that voucher was not turning over to other veterans. And so we were losing the voucher for those veterans that may need it. Fast forward to 2010, HUD-VASH was kind of reintroduced, rewired, and so forth. but specifically with the notion of targeting the most vulnerable veterans. One is because those are veterans who, if we not get them into housing as soon as possible, they run a real risk of, to be frank, dying on the street. And ideally, we don't want that to happen. So, and also too, by targeting those most vulnerable veterans, these are the individuals that probably are not going to come to you. So you need to reach out to them and go from, again, a waiting list, first come, first serve modality to a vulnerable, who's the most vulnerable. And so with that, just in fiscal year 2016, we served over 72,000 veterans who are housed through the HUD-VASH program. And this partnership between HUD and VA has been working pretty well. It's so well that communities are now looking at how to use those vouchers, because the veterans that are left that they need to use those vouchers for are not necessarily the most vulnerable because they've gotten them housed. So they have to look at another way of using those vouchers, and we are working with those communities. So what success have we had? I think I mentioned that we've had a tremendous decrease in the number of homeless veterans. Since 2018, we've almost had a 50% decrease in the number of veterans who are homeless in this country. And even so, those who are unsheltered, that number is roughly 57% who are in some form of shelter, still homeless but not on the street. And so we're working with them. That number now has gone from 76,000 to a little under 40,000 veterans who are homeless. And also since that time, we've seen 45 communities in 3 states declare that they've ended veteran homelessness. So let me be clear before folks ask that I still see veterans in certain communities and so forth. How can you say you've ended veteran homelessness? Well, if you recall, I talked about a systemic approach. And so our definition around ending veteran homelessness is that communities have systems in place in which they can target and get veterans into housing as quickly as possible. And that if a veteran is at risk of homelessness, they can prevent his or her homelessness. Or if they have a housing crisis and become homeless, that incident of homelessness is rare, brief, and non-recurring. We also have developed criteria and benchmarks in terms of those communities who want to declare to begin to measure and say, here's the standards that we're looking at in terms of what it means to end veteran homelessness. We all know that it's very difficult to say that there'll never be another homeless veteran. There are only so many things that we can control. But we can control having the systems in place that, again, if that veteran has a housing crisis, to help him or her get back into housing as quickly as possible, or prevent them from becoming homeless in the first place if we get to them fast enough. So in terms of what the VA was doing in terms of the approach to ending veteran homelessness, they put 6 pillars in place. Ramping up the outreach, making sure that we were going to reach every veteran, no matter where they were, but to make sure that we reach them, partnering with other agencies, partnering with community providers to find those veterans. Make sure that our treatment fits the need of the veteran, not having what you would call this one-size-fits-all, but treatment that actually met the need of that veteran to ensure his or her success. We also ramped up our prevention efforts. One of the things that we're still trying to get good at is how do you prevent a person from becoming homeless in the first place? And also, how do you know that you're actually preventing that person from becoming homeless? As so many folks that I've known in my lifetime, just because a person gets an eviction notice doesn't mean that they're going to end up homeless. So we have to do better in terms of identifying those risk factors and getting to those veterans before. But that is something that we're committed to. Also ramping up our supportive services in terms of housing and supportive services, working more closely with HUD and other housing agencies and ensuring that veterans not only get into housing, but they are supported while they're in that housing. And then employment and income are also key factors in terms of what we're doing in terms of sustainability for veterans, in terms of making sure the best way to end veterans homelessness is to ensure that they have a decent paying job and that they have income, where they can take care of themselves. And then continue to have community partnerships. There are gaps that VA itself statutorily or capacity-wise are not able to fill. And we need partners, whether they're community partners or private sector partners, to help us to bridge that gap to meet the complete needs of the veteran. Another program that we introduced as a result of
Frederick.
Moving.
That's the last slide.
It's two more. There we go. So another program that we introduced in terms of a resource for the community is our supportive services for veteran families. This program, introduced in 2011, was a way to not only serve the veteran, but to serve his or her family. It's actually, it's one of the few, if not the only program within VA that allows federal VA money to serve the family members of the veteran. This is a program that we use not only to rapidly rehouse veterans and their families, but to also prevent them from becoming homeless in the first place. Just last year, over 148,000 individuals were served with this SSVS dollar. 95,000 of those individuals were veterans. 32,000 were children of veterans. These are dollars that allow for the support of the veteran and their families. It pays for legal services and child care and other services to help that family become a whole unit once again, and a house unit at that. So, since we've made all this progress, what are we going to do and going forward? One, we have to maintain our efforts in terms of what we're doing. It's not an issue of you end veteran homelessness, dust off your hands and go on with life. A lot of folks, when we made the announcement that we were going to end veteran homelessness, they felt that after you end it, you just walk away, or maybe you go on Super Soul Sunday on Oprah or whatever you do to talk about it. But it's an ongoing thing, because not only do you have to end homelessness, but you have to sustain your progress. It's like I told someone the other day, it's like buying a house. You know, a mortgage is temporary, but maintenance is forever. So that's, that's what we will have to do with our systems. We don't want to see, us go back to where we were. So we will continue making progress towards that. The Secretary has committed that VA will stay committed to ending veteran homelessness until every single veteran has a place to live and is in permanent housing. And so what do we have to do? Well, we have to look at what's worked and have to look at what hasn't worked. Of course, we know that resources are not going to be abundant forever, so we have to continue to be more strategic in terms of where we deploy those resources. We have to rely more heavily on partnerships. Partnerships are going to be a cornerstone of how we go forward. I know within the homeless office, my job specifically is to go out and identify those partnerships, whether they be partnerships that help veterans who move into housing get furniture, or those partnerships that will provide job training to homeless veterans who are exiting homelessness. And we also look at other partnerships with landlords who would be willing to rent to veterans who maybe had a little spotty credit, but they're ready to turn it around and make some waivers for them, or if there's a little spot on their record, but they've served their time, they've made good, they still need a place to live, and landlords will give them a chance. So we build those partnerships. We have to get better with data and data sharing in terms of making sure that we know who we're serving and how we're serving them, and what progress we're making, and also just continue to evolve. As newer veterans possibly experience homelessness, their needs are going to be different than the veterans we served in the past, and we have to make sure we have the resources and the technologies available to support them. And I think that CVEBs in and of themselves will play a huge role in helping us to make sure that not only do we maintain the gains we made, but we continue to have that line go down and become steeper and, you know, look above and the numbers are really negligible, if you will, across the country. And so with that being said, are there any questions?
Very well, thank you.
Anthony, I'll just ask a question. So so your last bullet about CVEBs, do you guys have an interaction right now with the CVEBs, or how do you think we can improve the communication from CVEBs and the local community needs back up to your office and, you know, as well as CVA and stuff?
Right. Good question. I think we've had some conversations with CVEBs, not as robust as they need to be. But one of the things we would like to do too, we have community providers out there that are not as aware of CVEBs or are aware of the work with CVEBs, and I think that both our office as well as CVEBs within those communities, we can work with them in terms of engaging those groups that have been working long and hard in that community towards ending homelessness and ending veteran homelessness, and identify how they can, you know, align their efforts with the CVEB so that, you know, you're not working cross purposes.
Right.
I think that it'd be helpful to just identify, you know, where those CVEBs are in terms of ones that have the priority of homelessness and see how we can work better with them. I do think that there are communities that actually they're already doing it. If I'm not mistaken, I think Pittsburgh is probably one of them. And, you know, talk to them about how they were able to align with those groups and work with those groups and maybe work with other communities that have CVEBs and connect them as well the same way.
And I think getting your local coordinators involved with the CVEBs as well as our office is a good conduit, but I would also love to hear from the other communities on a way that they think we can best work together and get that information from your office and also the resources and information from your office back down to the local community.
Yeah, absolutely.
A question out in Boxborough. I work very much with the whole program, and my mayor actually had signed the pledge to end veterans homelessness. What I'm curious about is the new lineup of beds under the grant per diem program. How will the changes that will occur on October 1st help align that with the criteria for and the benchmarks that's also in the plan? Because it's very difficult to meet the criteria depending on the program or in the community or in the city or the state.
Right. One of the things that the quote, and I will use this term loosely, transformation of our grant per diem program, the way that it will help those communities is that all along the purpose of that was to ensure that those grant per diem programs were working in conjunction with the community, that they were at the table and the grant per diem program was meeting the needs of those veterans within that given community. As you're aware, within the grant per diem program, as opposed to just having this, what you would call all-encompassing transitional housing model, they've broken it down into 5 possible models. Bridge housing, home to hospital, clinical, service-intensive transitional housing, and I'm missing one. Is it transition in place or something like that?
Yes.
Okay. Yeah, so you have those 5 models, and ideally the communities that were applying for it really should have been having that conversation with, you know, their whoever is doing what you would call the organizing and the coordinating of homelessness, the homeless actions or homeless strategies within a given community, and ensuring that their application meets the need of, for example, if this community is like, you know, we really need more bridge beds, because as veterans are getting vouchers, you know, units are not available for them in a timely enough manner, and they have no place to go. Well, bridge housing would be the perfect thing for that particular veteran. Or a community that says veterans are asking for more clinical type transitional housing if they're not ready. They're telling us they're not ready to make that move. Well, then that particular approach would be much better. And the criterion benchmarks make allowances for veterans who make that choice. But it has to be the veteran's choice. Does that make sense? Okay.
Yeah, it does. It makes sense. I guess they're all still counted. And when I look at the criteria, it's like they're still coming in and going out at varying rates.
Mhm.
And I know that one of the benchmarks is you have to have less going in than coming in. Right.
Yes.
And that can, I'm wondering with these new beds, I mean, some of them are going to, I guess I'm not exactly sure how we're actually going to reach it when there's so much transition going on.
Right.
To be able to measure that, because there are people who are going to need all of those beds. And
yeah. Well, you know, you're absolutely right. One of the things that the new approach is, first off, it's fewer transitional beds than we were. I think it's down from maybe 14,000 to 12,000 nationwide, if not lower. Secondly, as I said, if the veterans are making the choice to go in those beds, there's some allowance for exempting those particular veterans for a period of time that doesn't count against you. But again, the demonstration has to be that the veteran has made that choice, and people are not just trying to fill beds just because they're there. But that the bed has actually been chosen by the veteran, and the need is being met.
very good. Thank you.
All right.
Thank you so much, Mr. Love. Great information, great presentation. I'm going to just briefly introduce our next presenter, Dr. Reagan Crump. He is our current Assistant Deputy Undersecretary for Health Policy and Planning. Dr. Crump serves as the Principal Advisor to the Undersecretary for Health on the development, implementation, and impact of VHA policy, system analysis, and strategic planning. Dr. Crump, thank you for sharing your time with us today. Dr. Crump.
Thank you so much. It's really a pleasure to be here. I'm actually in between two great conversations. You know, eliminating homelessness and eliminating suicide are two of the most important things that we can actually do, because health is obviously not just about health care, it's about so many things. What I'm here to talk about is a campaign, a movement. I'm not quite sure what to call it, but it's 100 Million Healthier Lives. It's an initiative to get groups, individuals around the country working together to make sure that in the year 2020, 100 million people are living healthier lives. Now, that may sound like a big, bold goal, and it is, but I think we can get there. So let me just walk you through a little bit. This is really a conversation, and I'm really focusing my remarks to the members of the Community Veteran Engagement Board. Because in my world, you know, I came from Health and Human Services. I spent 32 years working with communities. And, you know, when you have a group of different types of organizations working together, that's a coalition. And so I look at you as not just a board, but as a coalition. And this initiative for 100 Million Healthy Lives is a coalition of coalitions, really. It's about how do we work together. So let me go back to this first slide here, purpose. So I already said it had started about 2 years ago. It was a big meeting up in Cambridge. And, you know, there was about 200 people in the room. And as we started to think about how do we do this, how do you get 100 million people living healthier lives, we started to realize we had to break up into groups. We broke up into groups by certain domains. There was a group that wanted to focus on children, another group wanted to focus on mental health, someone to focus on seniors. And I happened to be at a table with DOD and Samueli Institute, and we wanted to focus on service members and veterans. And so when we thought about it, we said, wait a minute, if there's 100 million people going to be living healthier lives, and there's going to be 20 million veterans living in that year, we want 20 million of the 100 million to be veterans. And so that's what we put together as our goal. And so what I'm here to do is to share the intentions of this growing group of people, coalitions and organizations who are actually working together to do that. It just so happens that in VA, at the same time, Secretary Shinseki and others, really bright people, had the idea to create these community veteran engagement boards in my VA communities. And I only found out about the CVEBs a few months after we had initiated the 100 Million Healthy Lives. And I've been tracking your progress. I'm amazed at what you all are doing, because it's the same thing. It's the same work. And so I want to share a little bit about what I see as a possibility. There's a lot of folks working on this. Now, many presidents, the current president and others, have had a goal to support veterans and service members, either the president or the first lady. And one of the things in this statement, this comes out of Trump's vision that I wanted to pay attention to, is he wanted to make sure that they get to care wherever and whenever they need it. But it's not just about health care, it's about the whole veteran, including their invisible wounds. And so one of the things that we are really committed to is that it's about health, not health care. So it's the mental, physical, spiritual, and emotional health, and all the social determinants of health. So that's what we're talking about. And this is not VA run. It's actually led by the Institute for Healthcare Improvement, but their focus is not healthcare either. It's health and well-being. So these are just some of the principles in terms of how we've been working together. Just working together, that's the uniting. Co-designing, which you're designing in each community. We're trying to design support for what you're designing in your community. We're also talking about developing infrastructure, changing policies. Because you can do a lot with a lot of smart people working together, but sometimes you need to change local policies and national policies to support what you're doing. So there's a movement there too. Now, currently we have, if you go to a website, it's called 100 Million Healthy Lives, and the short is 100mlives.org. Okay? If you go to that website, if you just type in 100 Million Healthy Lives into Google, you'll get there immediately because it's got a lot of hits. Everything you want to know about it is there. I don't need to say another word, it's all on the web. But there are about 800 people, organizations that are already signed up. And what I would call your attention to is there's 500 action plans where in a community, that coalition's got together and they put a stake in the ground and they said, here's what we want to accomplish. And so what we're trying to do is collect all of the action plans related to improving the lives of veterans so that in the year 2020 we can know what were those plans, how many veterans did you reach, and were we able to get 8, 12, 16, 20 million veterans living healthy lives. And there's some metrics to this too, and I'll share that in a moment. So actually, that slide I just flipped through was about a grant. Robert Wood Johnson did provide a grant. There's a lot of organizations, foundations that have been giving resources to this. IHI, Institute for Healthcare Improvement, is actually donating a lot of their revenues to this effort. And so many of them, we've been meeting at hotels and they've been feeding folks, and we haven't had to pay a dime because they're so committed to this. Now this diagram here, this graphic, is intended to just show what we're all about. What's what you're all about. And when I go through this, you'll think, well, wait a minute, you're talking about what we're doing. So veterans are in the center. And we started looking at domains of well-being or the social determinants of health, whether it's mental health, spirituality, education, transportation, food security, or housing, whatever. We believe all of those are critically important. And so what we're looking to do is to get coalitions at the community level. I've got community veteran engagement boards down here. We've run into chaplains of the VA have joined us. There's another organization called Communities Joined in Action. They've joined us. They have about 100 communities. And what we're trying to depict here is that if we all work together and if we're addressing these determinants, we can improve the well-being of veterans. So any community that has a focus on, any community coalition that has a focus on veterans and wants to move any one of these social determinants, those are the organizations that we're looking to be a part of or connected with. So here's the theme. Working together to help veterans thrive. Pretty simple. We had to come up with a simple way to say what we're about in case people are wondering, do I want to be a part of that? And I already talked to you about the mission and the goal. These are the different areas of focus which were depicted on the diagram. The only thing I probably missed was safe neighborhoods. I think I hit on most of the others. The last bullet there, seamless transition from active duty to veteran status. That's one of the most important things. We see that as a huge choke point, a danger zone, because as you probably know, we don't do a good job between the Department of Defense and VA in making sure that when you finish and when you hang up your uniform, that you've got everything straight with your housing and your job and your healthcare services. So we're seeing a lot of folks fall through the cracks. I know you've seen that in the homeless program. And so that's an area of concern for us. So that's why Department of Defense is one of our major partners. We're looking at their healthy, like the Army has these community coalitions around the Healthy Base Initiative. So we're trying to connect what they're doing in DOD for Healthier Lives to what we're doing in VA so we can close that gap so people don't fall through. We also are trying to reach out to the state departments of Veterans Affairs. So here's some of the strategies that we've been discussing. This has been going on for a while. So we've talked about preventing risk of homelessness, risk of joblessness. Don't wait until it's happened. Look at the risk factors for it. That's why we are pointing at the gap between DOT and VA. But we also want to make sure that we look at the communities and make sure communities are embracing veterans. We came across a study, many of you probably know this. There's a study, I think it was the National Civic League did it, and they determined that veterans have a higher civic index than the average population. They serve more on neighborhood associations, in public office, and volunteering, because they're used to service. And so why wouldn't communities want to embrace people who are always going to give back? So we try to find little factors like that and share that kind of information. So we had a group of universities and researchers come together, and they came up with a tool. It's actually a variation of Cantrell's ladder. It's a validated tool for measuring well-being. And so what we're hoping to do is to get all of the organizations that are part of this to actually look at doing a sampling of the veterans and looking at the extent to which they improve their well-being in several domains: social, physical, mental, and spiritual. The one thing that was really nice, it took, I don't want to say an act of Congress, but when you've got so many organizations working together, it's kind of hard to add a question because we wanted to keep it to, it's only 10 questions in this tool. But we got them to add this important question, which is, have you ever served on active duty? That way, we'll be able to identify all of the veterans that have participated and the veterans whose lives have been improved. We wanted to get this tool in the census for 2020. We'll find another way to do a sample. That was a big, bold aspiration. So this is just a listing of some of the folks in VA who've been working with us. We have folks from obviously policy and planning and community engagement, but quality, safety, and value, the Homeless Veterans Program, patient-centered care, which looks at whole health and well-being, health equity, interagency health affairs, and now voluntary services. Voluntary services had a huge meeting down in Florida not too long ago. We were down there talking to them, and a lot of folks raised their hands and said, we want to be a part of this. Because they had coalitions like Community Veteran Engagement Boards working before this came about. I won't show you all of the internal VA participants, but I did want to show you a couple of the outside folks. Department of Defense. National Defense University has joined the effort because they consider health to be a national strategic imperative. Many of you probably know that a high percentage of potential recruits are not eligible to join the armed services because of diabetes and obesity, et cetera. So even the Department of Defense is saying, you know, we got to get out here and make sure people are healthier so they can go fight and whatever happens after that. Department of Health and Human Services, Health Resources and Services Administration, part of HHS and CDC. But our main private sector partner has been Community Solutions. Their main focus is on eliminating veteran homelessness. Institute for Healthcare Improvement, American Red Cross. And we're looking for national organizations that have state and local partners so that they can leverage resources to help the community coalitions that are working on improving veterans' lives. So, well, why in the heck would you want to do this? Well, I was thinking about it, and I have 4 or 5 reasons. Here's what I want to submit to you. Just take a chance. Just take a look at 100 Million Healthier Lives, the website. Don't you want to be part of a nationwide movement that would have Americans living healthier lives? Don't you want to be part of the coalition of coalitions is going to help 20 million veterans live healthier lives. I know I do. When I retire, I'm going to stay involved in this. I'm not counting maybe 13 months, but I'm, just kidding. But the other benefit is this website. If you go to the website, we've partnered with a university that's had a tool called Community Commons. Community Commons is a powerful web-based tool whereby if you join and you go into, there's a place called Measure What Matters. It's a part of the website. If you go in and register and say, look, our community coalition is going to help veterans. There's a box where you can check veterans or veterans on. And you put in your information about what your goals are, etc. It will let you know every other community coalition in your area and what they're doing. It's a way of getting connected. So that third point is that it connects you with other organizations in your community. Now, some of them may not be focused on veterans, but they may be focused on food security, and you want to partner with them to get that food security of veterans. Maybe they are working on something with veterans, and you didn't know it. So this is a way of joining forces in the local community. The other thing is we have amassed a large array of tools and information that we want to make available to any community coalition, CVEB, that wants to do. We've got things like health risk appraisal tools for veterans, training, and other resources. And as we get new information on grant opportunities, etc., our intent is just to flow those resources, flow the information, flow the tools to community coalitions, because our only intent is to get 20 million veterans living healthier lives. And we know, we've known for a long time that health care only contributes about 15 to 18% to the health of an individual. The rest of it is housing, employment, education, transportation, living in safe neighborhoods, safe water, all of that. So that's why we want to focus on those things, because in VHA, I'll say the VHA, we're pretty focused on health care. But across VA, we got folks looking at vocational rehab, GI Bill education, housing, home loan guarantee for housing, so many things. But this is so huge, there's no way we can do it alone. And I know in your communities, you're thinking, there's no way we can do it alone. So it's all about partnering. We say, do what you do best and partner for the rest. So I'm so happy to see that we're doing this in communities. If I retire to Durham, I'll come. I think I saw someone from Raleigh, Durham area, so I'll come see them.
Yeah,
That's part of what they're doing.
we're representing them.
Yeah. So anyway, that's really all I wanted to share. I just wanted to, share the opportunity, let people know about it, because not everyone does. I want to encourage you to jump in there, because in Measure What Matters, there's a whole array of tools for measuring health and well-being. Obviously we came up with this one because we want to be able to have a universal tool to look at health and well-being across the country. But also there's a suite of tools. You can do a drop-down menu and select tools and track progress in your community based on whatever you set as your goal. You may have set housing, jobs, suicide prevention, whatever your goal in your community is, you can do the drop-down menu, pull that up. But also you're part of a family. You'll get information as monthly calls or 100 Million Healthy Lives. And we don't have enough folks yet to do monthly calls on the Veterans Hub. We're doing about quarterly for the Veterans Hub, but there's monthly for the entire initiative. So join the movement. There's a form that, it's sort of a one-pager, a fact sheet that's going to be made available, I think, to everyone afterwards. It's called Join the Movement. But on this one page, it's all the information I just shared. So thanks for the opportunity. Appreciate it.
Thank you so much. Dr. Crump, I had two questions for you. Are we doing anything to acknowledge any organizations that are taking this pledge? One question. And then the second question is, a lot of these board members are dedicating extra hours, not the primary job. So what do you think the level of effort is per week, per month, to actually track the amount of veterans that they're touching, or just recognizing what they're doing on a weekly or monthly basis?
Well, two things. One, we have not done anything on recognition yet, but I think we should. I used to work in the choice program at VA. We wanted to come up with certificates and different ways of acknowledging people. volunteer, the main thing you want is a thank you. You know, you also want to see the fruits of your labor. You want to see that something happened. We haven't done that yet. That's something we do. In terms of time commitment, I certainly would not want to create any additional workload on anyone. If it's a part of what they're already doing, it makes sense. I think it might take 30 minutes to go in, to look at the website. If you're like me, you'll probably search the web, and 4 hours later you get back to what you went in to see. But it'll probably take about 30 minutes to go in and put the basic information in. People may want to track quarterly, they may want to track on an annual basis or once a year. And it's a matter of whatever you're already measuring, just pop it in so that everyone else can see your progress. If people want to connect with you, see what you're doing, maybe help you or maybe learn from you. Or they may see you struggling in a certain area, like I heard today. I heard a great conversation where people wanted to share some examples of what they've done, or they want to learn from others. And that's what community, and that's what coalition, and that's what partnerships are.
Right, and so my last question, sorry. When you think about, one, healthier veteran lives, what degree do you say, if I talk to a veteran and gave them some information on benefits versus I got them an appointment and see the doctor, would you say one over the other, or passing information on to a veteran, maybe they do something with that? That is helping.
Well, that is helping, and there's different, you can do process measures, you can do outcome measures. And I think a lot of folks are going to track outreach, how many people they've reached, how many they provided information to. But I think it's really, most important that we look at outcomes. And that's why we looked at that scale. What you want to do is look at their well-being at a point in time and look at it at a later point in time and see if they scored higher. You want to find out, did they get into a home and stay into a home? I used to work in a homeless program at HHS, and we always focused on the constellation. It was never just about housing, because we always had to provide health care, mental health, and jobs. Because if you lose any one, you're back on the streets. So, you kind of have to decide what your metrics are. I know those are a lot of different things to count for homelessness, so that's why you probably just take housing. So whatever the metric that the community appreciates is what we value, but try to move towards outcome instead of process issues.
Great.
What's your name?
Chris.
Chris. To Chris's point, I think that's really important because everybody wants to see outcome impact instead of input output, right? It's pretty easy to say we referred this many, but that's hard. Even if you give people the way to do that, it actually takes manpower to do it. So back to your original comment where you say if an organization is part of this incredible movement, they get some kind of veteran hub member or something that is, of course they're going to be more valuable to their clients, but it's going to create more work for them, which isn't a bad thing because they need to be able to show outcomes, but it's something that says, I'm doing this, I'm taking it to the next level by spending 4 hours a week getting the outcomes. You got to call them, you got to do surveys, and it's hard to do for an organization that has a line out the door, right? So to his point, to Chris's point, anything that we can do to recognize the organizations that have joined this movement, I think would be beneficial.
Well, I just made a note. I take that as a test. So my commitment is to go back and look at what can we do to create some recognition. I think I'll also talk to the folks that are working on it, my VA communities, to see if they have anything they're doing. But I take your point. It's great. And so I will look into that.
Awesome.
Yeah. And, the thing about measurement, by the way, I agree, when you're working in government programs, we always, because there's funding involved, because there's staff involved, you always want to show outcomes. But this is voluntary. And so you don't necessarily have to show outcomes. We want to, but you don't have to. If you feel good because you in your heart believe you helped someone, you've given them the information, it's on them, well, that's good. If we only help 20 million veterans, and they don't necessarily still live healthy lives, we've still done something good. So, thank you.
Thank you so much.
Thanks, Dr. Crump.
All right, our final presenter here is Dr. Caitlin Thompson. She is the National Mental Health Director of the Suicide Prevention and Community Engagement. So, Dr. Thompson. Just now?
Just now? Oh, okay, great. Hi, everyone. What an interesting way to present. So I'm really happy to be here today. I'm going to definitely make sure that that we stay on time, though. So I will make sure that you all get your break. That is so important. But I'm delighted to be here today. This is the first actual networking event that I've been invited to really participate in, and this is going to be a great model to then talk with the other networks about what everybody's doing and what you can be doing, and in terms of suicide prevention for our veterans. So with that, can you please make sure that I'm on time?
Sure.
Great. All right. So I just want to give a brief overview of suicide prevention and suicide rates. So across the country, we know that there has been an increase in suicide rates between 2001 and 2014. So it's increased by 23%, which is really extraordinary for all people. Last year, we were able to put out a suicide data report on all veterans that summer based on 2014 data, because that was the data that was available through the CVEB. There's usually about a 2-year lag, so we're hoping to have our next data report sometime in the next number of months. But we see that, as you can see, veterans also had increased rates of suicide. And especially when you look at the female veteran population. So those rates of suicide have increased so dramatically, 85% between 2001 and 2014. For men, about 30%, 31%, just in general, 32%. That said, one thing that we have found that the rates that have increased over time for veterans who use VA services, even though there's still an increase, the rates have gone up at a smaller pace than those who do not use VA services. So we have some real opportunities here and this is especially where you all can come in and help, is to really marry VA with the community in order to make sure that the community has the information available about what VA does, and as well as the VA locally finding out what can be done within a community system.
Hey, Caitlin, really quick.
Yeah.
Is the 38.6 did not use VA services of the 22 million or the 9 million enrolled, or the
of the 22 million?
Of the 22 million.
Correct.
Yep. So not every single person might even qualify for the VA that's been counting in that number.
Exactly. Yep. All right. So what are we doing? What do we all need to do? We say that suicide prevention is everyone's business. This is especially important as we're talking about all of you in the community boards. One thing that we are doing across the VA is really engaging leadership and making sure that they're aware that this is everyone's business, and making sure that there's buy-in that suicide prevention should be a top priority. Dr. Shulkin has made sure to let everybody know that suicide prevention is the #1 clinical priority for him. It's extraordinary. It's very similar to what happened with the homelessness initiative a few years ago, in terms of really focusing that attention, making sure that everyone across the board was aware of homelessness, and engaging everybody around that cause. And so I'm frankly thrilled that the Secretary has decided that this should be the cause to rally around. Our strategic community partnerships are essential. We also provide gatekeeper training to everyone at VA. Gatekeeper training is what happens when we're training people who happen upon a veteran and may just need, and may be concerned about them. What do? How do you, what signs do you look for? And I'll go through a few of those signs. But this training is also being rolled out nationally. We have our suicide prevention coordinators, who I'll talk about in a second, provide it to VSOs and to other organizations, and really, connect with you all and be kind of that suicide prevention expert in your local areas for veterans. We know that treatment works. We know that when people get care as they're feeling suicidal, we know that once they get into treatment, most of the time they don't have a suicide attempt again, or they don't feel suicidal again. It's particularly important. Another thing that we really could use help with, I think pretty much everyone around the country can use help with this, is education and safety related to lethal means. So something else that we know about veterans and veteran suicide is when veterans are feeling suicidal, more often than non-veterans, and more often than not, they use firearms. Veterans are comfortable with firearms, they have access to firearms, and but we also know that if you're feeling suicidal and you use a firearm, there's a 90% chance that you will die. If you use another means, if you use, for instance, an overdose, there's only about a 3 to 4% chance that you will die. So lethal means, the type of means that people use when they're feeling suicidal, is extremely important. So this, so we have our gun safety locks that we provide to veterans. We can provide them to all of you in terms of any outreach events that you have. You can just pass them out, and there are no questions asked. We don't, of course, any gun registries or anything that has come up as being a concern, but in fact, this is for safety. And then we do a lot of research and have a lot of data that we are continuing to look at. Another thing that we always like to promote is Veterans Crisis Line, which is an extraordinary service. I worked there for 5 years as the kind of clinical lead there, and when I started, there were about 40 responders, and by the time, and right now, there are over 600 responders between 2 sites in upstate New York and in Atlanta. Why? Because people are calling, and there is a need, and they have received millions of calls at this point, and it's a service that also really, I need to make sure that slide is updated, it isn't just the Veterans Crisis Line, it's also the Military Crisis Line, so it's also for service members as well. These are the people that you should be connecting with locally. These are our suicide prevention coordinators. There are over 400 nationwide. There's at least one at every VAMC in the country, and they are responsible for their geographic region in terms of outreach, in terms of crisis line consults that come through. If a veteran is calling the crisis line and they need to follow up care at the local VA, the suicide prevention coordinators are the people who really make sure to have that happen. The veteranscrisisline.net website has a resource locator on it, where you just type in your zip code, you click on Suicide Prevention Coordinator, you find out who they are, you have their information, and I really recommend that everybody in some way get in touch with their local Suicide Prevention Coordinator, at the very least to introduce yourself. Also, if you come across somebody or a veteran or a family member is talking with you and they say, I'm really worried about this person, they are the people that you can just call directly and get some follow-up care there.
Did you say they would come out into communities and debrief?
Oh my gosh, yes, they do that all the time. In fact, they are required to do at least 5 outreach events in their communities per month. So,
and so if there's 400 of them, and there's, I don't know how many, it's not that many that are treatment facilities, are some of them in like CVOCs or vet centers?
Yep. Exactly. Not in vet centers. These are CVOC and large CVOCs and medical centers. Regardless, they still oversee the entire region, whatever the medical center region is. I'm really glad you brought up vet centers though, because we are also getting a much stronger collaboration with our vet center partners and making sure that we're passing along information. But they don't have specific embedded within the vet center. but they have them, you know, within the region where the vet center would be.
And there could be one more SPC in one facility. You could have it more.
Exactly. So, and it's also something that we're really looking at because, for example, when we look at our state data, and this is not just veteran data, this is suicide data in general, the areas that have the highest suicide rates, but not the highest numbers, but the highest rates, are the mountain states and Alaska. So Montana and Colorado and Arizona, those areas have the highest rates of suicide. But for example, in Montana and Wyoming, there's one suicide prevention coordinator who covers basically the entire state because there's only one medical center there, as opposed to a place like Atlanta, which also in fact has some pretty high rates of suicide, where there were about six suicide prevention coordinators just for Atlanta. So we are really looking at ways to better resource, better understand what the needs are across the country, because even though Montana has a small number of suicides, they also are very, very high risk because of things like it's a very remote area. There's a lot of firearms in the state. Veterans tend to really isolate there more. So.
Hey, Caitlin, just a quick question. With Reach Vet, the local coordinators trying to do Reach Vet, and I understand about maybe 60% of your local coordinators are doing Reach Vet, or maybe 60% of their time. So is there still that expectation that they have to do 5 outreach events a month? Wow.
Yes. Yep. So they are incredible, and they are incredibly overworked, and we are trying to get them help. So thank you for asking that and acknowledging that, because boy, it's been tough.
So are you guys trying to hire more? Are we trying to get more?
Yes.
Do we need more?
Yes. Oh my gosh.
Do you know, I mean, what you're looking for? Another 200? Like what?
Yeah. So we have put out there that we would be looking for like 1,000 for all of the initiatives that are coming up, because we just keep throwing things at them, right? The Reach Vet, which I'll talk about in a second, the outreach. The other thing that we're also looking to do is to hire a peer support specialist to specifically work in the suicide prevention areas at each facility, and that would really be helpful for some of the work.
And so then is this a congressional ask? Like, is this?
So at this point, we're looking at budgets and that sort of thing. I mean, in VA in general, we still need, I think, a couple, like 20,000 or so mental health providers just to fill those spots. So, you know, I think that it's both a congressional need, but it's something that we are needing to look at internally and figure out, and it's certainly a high priority.
Well, how much of that is money? How much is pipeline? We just don't have enough mental health professionals, right? That's not just
exactly right. Yeah. And it's not even just mental health professionals in VA.
It's across the system.
This is our SAFE training that we do provide. This is that gatekeeper training, the things that we provide and let people know about the signs of suicidal thinking, how to ask the most important question of all, which is, are you feeling suicidal? Have you thought about taking your own life? Validating the experience and encouraging treatment and expediting getting help. I would say, and I would recommend that if any of you and your groups want to take this SAFE training, get in touch with your suicide prevention coordinator. Let's make that happen. All right. This is the Reach Vet program that Chris was talking about. So Reach Vet is where we are looking at an algorithm. We are looking at veterans' medical records, and we are able to really find out who is at the highest risk for suicide. So the highest 0.1% of a group that is at highest risk for suicide, and then we follow up with them. So each VA receives a list of names of veterans every month, and there are outreach calls. This has now been nationally done, and we're doing the evaluation right now, but anecdotally it's being shown to be very helpful for veterans who are like wow, I never expected to hear from the VA to find out how I'm doing and to make sure that there are gaps being filled in. So you'll be hearing a lot more about ReachMed. It's a pretty exciting initiative. Here are our gun locks. They actually have the Veterans Crisis Line information on them. We also have a really powerful gun safety video, if you've never seen it, at veteranscrisisline.net, as well as a ton of our other PSAs. I also want to make sure that you are aware of, and we'll pass this information along, of maketheconnection.net. This is a site where veterans, there are hundreds of videos of veterans of all backgrounds, of all ages. I can put in that I am I can tailor the experience on the website to me, so I can say that I'm a combat Vietnam veteran male who is having relationship problems. And only like 4 out of 5 of those things are true. I'll let you guess which one. I'm not a veteran, but I then can click on OK, and then the videos that pop up are of all combat Vietnam veterans who are male, who are struggling with it, who are getting better. And so that's the hope. That's the lessening the stigma. That's the importance of really talking about this, because we all hear about the devastating stories about suicide. One of the last things that I also have a ton of other resources that you can just go through and make sure that you know about. One of the final things, two final points. 65% of veterans who die by suicide are 50 years old and older. I'm going to say that one more time. 65% of veterans who die by suicide are 50 years old and older. This really changes the narrative that most people across the country think about when they think about veteran suicide. Because so much of the time they hear about, and rightly so, because definitely this is a problem with our youngest veterans, but they hear about the veterans that come home, are devastated by whatever happened to them while they were in combat, and die by suicide. So I'm here to remind you and tell you that your older veterans are the ones who, in fact, at very, very high risk. And as they continue to get older, as our Vietnam-era veterans continue to get older, that risk is only going to escalate because of things like physical pain, physical health problems, loss of a spouse. Those are times when we know that suicide is where people are most vulnerable to suicide. The other piece that I want to make sure you're reminded of are the women, are women veterans, and really engaging them, making sure that their voices are heard within all of your community engagement boards, and learning from our women veterans to find out what we can do that is best for them. I don't think I have anything else right now, but I'm happy to take any last-minute questions. I think I did it within my time frame. So,
Oh, excellent.
Yeah. And you can get in touch with me at any time, and I'm happy to engage more. But I'm really, again, thrilled for the invitation, and we'll come back again at any point to update or talk through any other questions you have. So, thank you, whatever.
You mentioned a gun safety video on the veteranscrisisline.net.
Yeah.
I'm looking there, and looks like there's a lot of great resources there. Do you know what the title of that was, or?
Yep. So, are you in the video section of it?
Yes, ma'am.
Yep. So it's the one. I think it says firearm safety video. There's like 2 hands going like that, like the.
Okay. Yes. Yep. Okay. It's These Hands PSA is the title. Okay.
I don't think it's the These Hands one. It's I'll quick find it and I'll let you know.
Thank you.
Sure.
It is super powerful. One more question for you.
Sure.
You said in the beginning with the crisis line that you had active duty veterans, family members calling as well.
Yes.
We know that family members are sometimes calling on behalf of the suicidal veteran.
Yes.
Have we gotten to the point yet where we are tracking family members who are having their own mental health issues and being able to, because that's been, as you know, one of my big things is how are we tracking suicides and attempts and ideations among the family members, because it's just very hard to capture that. I know HEDA now has that in DOD, they have a way of doing that.
Yeah.
Are we getting any kind of information from the crisis line, or?
So we can get some information from the crisis line. I think it's pretty limited for family members and friends. And because we're VA, We still do not care as much as we should for our family members, nor do we track them as well. So that is certainly something, and Keita and I talked about it too. Keita is the head of DOD's suicide prevention office, about how to kind of move that data across the board for VA, but it isn't as it should be. And I think that it's also a problem because we're mostly a medical system, whereas DOD is much more of a broader, system.
Right.
So something to keep talking about.
Yeah, I mean, just being able to actually have, if there's a way if someone calls in, if they're a spouse, and a way to capture that this spouse has called in for their own suicidal ideation. Even if there's nothing else that we can do than give them to the other crisis line that's the general one, at least we'd be able to get a count of how many people are called. Because right now, as a community-based organization, if I have a suicidal wife, which we have far too often, I do get on the crisis line if they're a veteran spouse. But I just don't know if that's being captured. I know it's not everything, but at least we can start getting some data for that.
Absolutely, yes, and we definitely are through the crisis line.
Right.
I don't know it.
Thanks.
Hey, we have a question here in our room in Manhattan. We also have one in Morristown. I believe Rebecca is still at Morristown. Rebecca, you posted a question to WebEx. You want to ask that question?
We were just wondering if we would, as the VE team, have access to suicide prevention materials and gun locks because we are out in the community on a regular and recurring basis.
Absolutely, absolutely. So you can receive some local materials from your local suicide prevention coordinator, but you can also reach out to our office. And we can try to figure out what we have and what we can provide to you. Furthermore, on the veteranscrisisline.net website, there are a ton of materials that you can just download and put yourself. So I'd encourage you to do that too. But for sure, this is again just a great opportunity to spread the word.
Caitlin, we've also been working with your office to develop the toolkit for our communities, which is just ton of great resources, which we're able to help the communities and the local coordinators kind of work with communities to kind of filter through to see what would be applicable to that community.
Yes, so. Thank you so much for that.
Absolutely.
Manhattan?
Hi, Doug. Thank you. In our area, we, as have most of you, we've experienced a troublingly and alarmingly high rate of veteran suicide. And about 5 years ago, just shy of 5 years ago, our county, we're a county of about 1.6 million people. We've got a large veteran population. We created a veteran and military suicide prevention task force. And one of the things that we do as a part of our task force is we work closely with our medical examiner. And as we do in the military, whenever there is a completed suicide, we try to investigate to the extent possible. And one of the challenges that we've been that we routinely encounter, and I understand the need for it, and I understand the value of it, but when we try to get into doing a forensic mental health autopsy on these completed suicides, we slam full speed right into that HIPAA brick wall. And the information sharing is, and in many instances, unfortunately, in at least some of the instances, my office has POA. We've got completed consents in 2122s completed by these veterans. So we have consent to access military personnel and VA recs on these veterans, but VA tends to hold that consent does not survive the veteran's death. And we can't complete these investigations to the extent or in as thorough a fashion as we would like. Any suggestions? You have a magic wand over there you can help me out with on this one?
Boy, I wish. So just so that you know, we do a similar process. It doesn't sound like it's as intensive as yours, but we do what we call a behavioral health autopsy on veterans that we hear about who are within VA. So if you're doing them with veterans who haven't touched VA, that would be such important information for us to have as well. But we are able to then contact a family member who we do kind of a follow-up interview with after the veteran's death. In terms of the HIPAA stuff, I mean, what I can encourage you to do is reach out to me, and we can try to get our data people talking to see what is possible. And they would know far more about the limitations. But boy, I hear you, and it's frustrating.
I mean, we're working on an our county attorney, but I have no confidence that it'll get past general counsel. We're working on an MOU draft. We all agree that this is valuable information, but when we prohibit who can access this information, and it's for very specific purposes, it's not for general, information gathering. This is very, very important. And we do have a next of kin consent that our medical examiner does provide to family members, and we're always respectful of their wish or their need for privacy. Families are not always prepared in the moment to get involved in these types of discussions. So, I'll shout you an email if you don't mind.
Please do, please do. And it is so interesting because there are some family members who are ready, they want to help, they want to talk about it, whatever, and then there are others that are like, I can't. And so it's respecting everyone's experience. Because
we all grieve in our own way.
Suicide is just absolutely devastating.
Can I just touch, as long as I have the floor?
Please.
One of the other things that we encounter, and again, we have a significant veteran population, so we speak to a lot of veterans on this. The issue of firearms. Places like New York, a lot of the urban places, there is a perception or a point of view relating to firearms that differs from much of the country. And we believe, in many ways, that some of VA's policies regarding firearms and reporting disincentivize veterans, because we are a gun culture. We disincentivize veterans from coming to VA with certain mental health needs because of the fear of having their access to firearms restricted. And we see this, not even with mental health necessarily, but with the DIC when we get into declarations of competency and things of that nature, where VA reports to FBI, and these veterans are entered into the NICS system, and they can no longer pass a federal firearms background check, and it truly disincentivizes a lot of our veterans from coming to VA. And I'm just hoping that if we were to maybe begin this discussion, that we could find a workaround that would accommodate both sides' needs and still allow us to achieve the ultimate goal.
Yep, you're absolutely right. We've been my team, and Dr. Megan McCarthy is my deputy director, and she's one of the primary voices in terms of firearm safety and firearm lethal means reduction for veterans. And then there's also the issue of with VBA, who is, if a veteran is not deemed competent to take care of their financial information, then their firearm is typically removed. The last thing that
and that issue of competency does not necessarily have to relate to mental health at all.
Exactly.
It can be mobility. It can be a question of ventilation. Right. So many other factors.
Yeah. I totally hear you. And we've worked with veterans quite a bit in terms of talking through a lot of this. And the other piece that we're also trying to do is really encourage the use of peers to talk with their friends and their peers about firearm safety. So we're rolling out a big lethal means education toolkit in a way for providers to be able to feel comfortable asking the question when all of these issues are swirling around in the background, in terms of talking about this, as this is not a Second Amendment issue. This is an issue about safety. This is an issue about family safety. But you're absolutely right that it is very complicated, and so as we continue to work through it, I would love to continue to get all of your perspectives on how to best manage that.
Okay, then I'm going to have to jump in right now because we've gone a little bit over our time. Thank you very much for your
That was our fault.
No, it's no one's fault, but I certainly appreciate it. And I know we had a short little break set up, but we did go a little bit over time. And Dina, we're a virtual conference right now. Is Dr. Davis on the line right now? Dr. Davis, do we have you, participating online?
You do have me, Jim. Can you hear me?
That's great, ma'am. Let me take a second to introduce you. Everybody, Dr. Davis is our chief Veterans Experience Officer, replacing Tom Allen. Dr. Davis is a presidential appointee, and she is the lead for us in Veterans Experience. And I certainly appreciate the time that she's taken to talk to this virtual group as we're going through. And in the spirit of it all, Dr. Davis is phoning in out of her busy schedule to take some words out and have a discussion with us in the North Atlantic District and the way we've gone through and forward. So, Dr. Davis, please, the floor is yours right now. Or the telephone or the conference call is yours, I guess I should say.
Well, it's my schedule is secondary to everybody's on call, and I greatly appreciate, Jim, that you and Andy and Chris and others have pulled together this important meeting. It's being able to talk to our colleagues and peers and share information, even virtually, is invaluable, and I think it's a great format. So thank you for trying this. And it, there's a lot of ways to use this going forward as we have new information, and in fact, as we put in place for the secretary a monthly effort on communicating and focusing on one particular area that is a priority for improving our services to veterans. Certainly the discussion that I just heard a part of that had to do with mental health and suicide, etc., is one of the key areas for the secretary. So thank you for making the opportunity available to share information. And it is a two-way street, so being able to listen is so important. I know you had some great participation from people like my friend Mark Graham and I think Jim Lorraine and others. And I want to make sure through you that I'm able to hear what the experience and needs of the veteran are in the field. For those of you who don't know my own history, I'm a former signal officer, the mother of a soldier, a wounded warrior, and I have spent extensive time both at DOD in different leadership positions and working especially on our Wounded Warrior Stand-Up After Dole Shalala Commission, and then also working with the VA as a clinician years and years ago. So I am here to support the efforts that Jim is leading with the CVEBs, not only in this region but across the country. And just appreciate if there's anything that's important that you'd like me to hear now, I'd be glad to listen.
Any questions?
Hey, Linda, this is Christy. How are you?
Fine. Hi, Christy.
Hi. Can you just explain a little bit more about this? I guess it's not a new office, but just there's been some shifts since the new secretary took over, and just trying to figure out, particularly if you're a community organization, like who's kind of in charge of what. I know there's a lot of community integration efforts, which is great, but I just want to make sure with all those great efforts that we're not kind of falling through the cracks between the integration efforts themselves. So can you talk a little bit about what your office's responsibilities are?
The major responsibilities of the Veteran Experience Office haven't changed with the change in administration. 2 years ago, Secretary Bob stood up the Veteran Experience Office with the intent of bringing the best practices of industry in the area of customer service into the VA to infuse the VA across the entire enterprise, all three administrations, with an approach that was explicitly veteran-centric and focused on the experience of the veteran being the best it could be, almost like what you'd say in the private sector, a customer service focus, using not only our frontline staff in face-to-face interactions, but also using qualitative and quantitative tools that could help us ensure we're understanding the experience that the veteran and the family, caregivers, and survivors are having at any one point in their interaction with VA, that we're taking that information and identifying the challenge, or what we like to call kind of the pain points, and that we're able to feed that information in a real-time basis to those who have responsibility for managing the delivery of care and benefits, so that we can help improve that. So there's a continuous process improvement and greater accountability. So one of the ways the CVEBs and the community relationships are one of the ways in which we can better understand the experience of the veteran. And it, of course, is a critically important one because it's the face-to-face interaction, and it allows us also not just to hear through the community outreach what is needed by an individual veteran or a community, but also it allows us to share information. So it's a two-way relationship there. And Christy, this is, you and I have been working at this a long time, and you've got some exceptional efforts and tools that so you appreciate the value where it's appropriate of bringing in technology. And Jim, I'd be delighted to have a virtual presentation, not only for, this district, but for across the country with the CVEBs on the tools that we're going to be putting in place, and that we're working particularly starting with the VHA and working with the different visions of how we can improve the experience of the veteran and their family as patients using inpatient and outpatient services. I think it's really pretty impressive, to the point of asking the veterans after each interaction to let us know how that interaction was, whether it's ultimately with the physician or with a particular department or with a facility, so we can get feedback and constantly improve what we're doing.
Ma'am, this is Jim Watsky. We opened up our conference, my remarks, in which that was one of the thoughts I had, is to have a virtual conference from coast to coast as our next near-term future goal.
Great.
Any questions? You guys?
Any questions from any communities? Or are we on you?
Well, I appreciate again the meeting that's occurring, and if there are questions or recommendations, suggestion, requests, let Jim know, and I'll be available to you all anytime. I appreciate what you're doing, and we want to make sure that we are, truly listening to the input from our community partners. So thank you all for everything that you do. It's the most important thing we have in terms of touching our veterans. One thing I would like to know is I'd love to hear any examples or feedback or suggestions on approaches to addressing support for veterans and their caregivers who need respite. If there's any good models, good services out there, I'd like to see that or learn more about that. That would be very, very helpful. And I'm sure somebody has mentioned to you all that we have a new federal advisory committee starting that is the Veteran Family Caregiver and Survivor Advisory Committee, and the nominations are due today. So if you know of anybody who might like to serve on that, please send their name in as soon as possible.
Sorry, one more question that you just asked. Like, with the respite, you know how the SSVF grant has worked spectacularly well in terms of housing and homelessness? Is there a way to do something like that for respite? Like, so if you're funding community-based organizations to provide housing and homelessness prevention, could we look at that same model to provide respite through, like, I don't know, Easter Seals or whoever else is doing it out there?
Christy, I think that's the seed of a very good suggestion, and I would, given that there, if you've seen the clips on the Choice or Community program, you know that there's a very tight budget constraints right now. Given that, I would encourage you to pursue that line of thinking.
Gotcha.
And in fact, it's not. Some of that is already that's the answer way. But as always, is a brilliant thing to observe. So thank you.
Thanks, Liz.
All right, you guys have a great day, and I appreciate it.
Thank you very much, ma'am. Thank you. Appreciate the time. Thank you. Here, somebody. Hey, all right, we are just about done. We had a scheduled break. I have a feeling if we take a break, about half of the people that's left are not going to come back. The rooms are quickly thinning out. We really don't have a lot left. Does anybody need a break, or should we press on and go ahead and wrap this up? Press on, Tony. Press on. All right, outstanding. Hey, everybody can see the agenda slide that's up now. That's our cover slide. I referenced this earlier. Along the bottom there, you see there's a link that says speaker bios available at. Several people have been asking about this throughout the day. We're also going to hang all of the presentations that you have seen here today. They won't be up until tomorrow, but all of the presentations will be there. Also, that's you'll see the second link there is the post-event survey. So encourage everybody to take that survey, give us your feedback. And so now what we're moving into is any final questions or discussion points. And that can be anything that we've covered today. There's been a lot. It's been some great conversation, a lot of good questions asked, a lot of good information put out there. So the floor is open to anybody. Anybody has anything they want to bring up before we call it a day?
Hey, Tony, this is Chris. Really for Lori Barone. She had a question about rural communities and homelessness efforts. Unfortunately, Anthony had to take off to walk the parking lot for a question and get a response from him offline. And then, Crystal, you were doing?
I did. I had a question, but question was for
Anthony.
Yes, and he's gone. So.
Okay. So we have two questions for Anthony. We'll parking lot, get offline.
Okay. Anything else?
And Foxborough has a quick question.
Okay.
I'm curious of, all the things that we talk about, and resources are limited. The money that the VA has a line item every year for stand downs to bring in homeless veterans that are outside. Well, I think we all know that that's no longer the case, that they're outside some still are, but I mean, many are connected with services. And I was just wondering if the VA has have any ideas of what to do with that money rather than this continuous pool of stand downs that have its purpose, but maybe a little bit outdated?
I do not, have an informed opinion on that. I don't know if anybody else, out there does. I'm getting a head shake.
I got another question when you're done.
I'm not, this is Martina Prue, the director of the VA New York Harbor here in the city. I'm not aware of any earmarked dollars for stand downs. Are we encouraged at times to do stand downs? And I agree with you. If you're doing a stand down, hasn't really gotten us a lot in the last couple of years because, as you said, they're not on the streets. And that's because of the success of our homelessness initiative. But I don't know why you think we're getting dollars just for stand downs, because I know in my budget I'm not getting money specifically for stand down.
Can I jump in?
And I don't work for the VA, so
I can tell you the VA would know.
I think, and I could be mistaken, but in my experience, any of the stand downs that we have ever hosted, and we stopped hosting them several years ago, and now we partner with our medical center and they host them. But any grant funding that was ever made available to us on the stand downs did not come from VA, it came from DOL.
Okay. So I guess I was just wondering if there's a better use of the monies, but I thought it came from the VA, but if it comes from the DOL, wherever it comes from, it just seems like there might be an opportunity to use it in new ways, to reach as many veterans, whether they're homeless or not. I guess it's just kind of what I'd like to see addressed at some point.
Okay, thank you. We have a question here from Todd.
Yes, we got a question on the internet from Rebecca. She wants to know, if anyone can answer this question, please. Does the VA participate in the National Violent Reporting System, or NVRS? Does VA participate in that?
I don't think so.
Yeah.
I don't think so.
Can you say what it is again? The National Violence what?
National Violent Reporting System. No.
Can you provide context on the question?
So it's happening.
Like what it?
It's in relation to violent death, and number of states were pilots. They're up to about 34 states that have started to participate in it. And one of the reasons that it's important is because a lot of times when there are deaths that are suicides, they don't identify that they are veterans when they go through the ME's office. And the states that are using this system actually do identify them. So at a national level, collecting of the information, we wouldn't have to trying to get each state to release the information. It would be in a national database, and we'd have a more accurate picture of veterans and veteran suicide.
Caitlin, who's left, but you have her email, is probably the best person to answer that question, because I know that they've been doing a lot of pulling of other national registries to try to get at some of those numbers. So I would suggest whoever asked that question to email Caitlin directly and ask her, because they might, or if they're not, they probably should be. So. Yeah.
Okay, we have no other questions coming over WebEx. Any other parting questions, comments, observations from any of our remote sites? All right, nothing heard. Then I'm sorry. Go ahead.
Are we going to get PowerPoint presentations like sent to us of what was on here to everybody that participated?
It's already on the invitation.
Yeah.
Okay.
Yeah. Just again, in case anybody missed it, can you see the agenda slide that's up right now?
Yeah.
Okay.
Yes.
There's two links at the bottom of that. It says speaker bios available at. That's where the PowerPoint slides will be hung tomorrow. And rather than me try to email those out to everybody, we're just going to hang them on the website so everybody can access them. Okay, then with that, I just want to say that, you know, a couple of months ago, I started working with Cisco, started out with, Petra, talked with her about some possible solutions for bringing this thing together. Then she hooked me up with Vinny and Patty, and they've been holding my hands for the last couple of months, just helping to bring this thing to fruition, and slowly other folks like Matt and Mike, Nathan, everybody else out there. So I just want to offer my sincerest thanks to the Cisco team. Thanks to everybody for coming out and joining us. I know that this is a big ask to take an entire day out of your schedule, especially for, you know, busy folks like CVEB co-chairs and county directors, veteran service, medical center directors, vision directors. So thanks a lot, and RO deputy directors. Thanks a lot to everybody. And I know that Jim wants to make a presentation down there in Herndon, so I want to turn it over to Jim for his final closing comments and the presentation.
Thank you very much, Tony. I certainly appreciate it. And Andy and Chris, why don't you guys come on up here with me too, as part of our CVEB team. This has really been a fabulous event. A lot of work, and I'm going to just caveat onto what Tony has already said. The work that went on is absolutely fantastic. Not only for everyone given a whole day in knowledge and sharing and networking, which is the principal objective, but the bottom line is serving our veterans through the CVEBs, through the efforts that you all do, whether it's medical center directors, business directors, ROs, CVEB co-chairs, volunteers, 501c3. We're all coming together in a nucleus of cities and supporting our veterans, and that's great. But the glue who put this all together for us, so the mechanical portion of it, can't be remiss. And therefore, as Tony has said, I'd like to recognize the works of Cisco. And I'm just going to mention a couple of names. And Jay, could you come up here for a second, too? And Sean, just come on up here for a second as well, as I have my team behind us. But in the Herndon area, we have Sean Jeffries, we have Jay Milliken. That's great. McCarron. Thank you. In Pittsburgh, we have Eric Vizana. In Richmond, Virginia, we have Anwar Mallory. In New York City, we have Matt DeHaven. In Foxborough, we have Vinny Chin. In RTP, we have Zane Tarakin. And in New Jersey, we have Patty Trimbev. Our remote sites are supported by Nathan Gilbert, Mike White, and Petra Brzozowski. And I hope I haven't left anyone out, but I would like to read this presentation that we would like to give to them. And it's a certificate of appreciation from the VA, from the North Atlantic District, going to Cisco, and it basically states, the technical support and expertise you provided was essential in making the first Community Veterans Engagement Board networking event in the North Atlantic District a successful event. Your support allowed community partners to share and learn from each other in support of further development of their boards. We thank you for being a part of this journey with us, and we look forward to working with you in the future to provide the best service to our nation's veterans and their families. Presented today, June 15th, in Herndon, Virginia. Sir, thank you very much, Jay. If I could present that to you, and certainly appreciate, and Sean, thank you very much for your we also have another quick presentation that we'd like to do in Julissa. We're going to need your assistance on this, and my deputy, acting deputy, is going to be filling in. So, Chris, if you could take care of this one.
All right. Well, I appreciate Julissa for kind of being my avatar over there. Tony, Julissa, if you wouldn't mind standing up. So this event obviously took a lot of work, and outside of trying to do a lot of the community work and a lot of other things going on within the Veterans Experience Office, Tony, right after we asked you to not only plan and manage the NAT face-to-face meeting in New York City, right afterwards you were hit with being asked to plan and manage this great event that happened today for the last few months. So with that, Jim and I would like to honor you with a certificate of appreciation presented to Howard Tony Davis for your support in planning and managing the North Atlantic District's Community Veteran Engagement Board networking event. Your involvement and dedication made you an invaluable resource whose attention to detail ensured every aspect of the event was thought of thoroughly. Your commitment towards building a relationship with Cisco allowed the event to be broadcast with the top-of-the-line networking equipment, which kept costs down and quality high. We thank you for accepting this responsibility and sharing its success in order to share best practices and lessons learned with our community partners. Signed, Jim Wortsky, District Veterans Experience Officer. Jim, anything you want to?
With that, we have another event for you to plan here soon.
Tony, you've done a great job, as always expected. Thank you very much. And yes, I do need to pay for your lunch at Chipotle pretty soon. Great job, Tony. And thank you for your support to all the New York team. Jaleesa, you've been terrific too and helping us out in this. So thank you all, and I'm looking forward to getting back to the Big Apple soon. Thank you.
Great. All right. Tony, any closing remarks? Anyone else?
Yeah, Chris is buying the beer for everybody there. And I'm pretty sure that's accurate. And
I got a hockey game tonight, so that's perfect.
Okay. All right. No, thanks a lot, everybody.
Bye bye.
Thank you.
Awesome.
Thank everybody.
Thank you. Can I do it?
Thank you.
Not bad.